Management of a large acetabular chondrolabral injury in a young patient with femoroacetabular impingement. This is the case of a 19-year-old male that had to stop pitching for his college baseball team due to recalcitrant atraumatic left hip pain. He received one steroid injection by a referring orthopedist with some relief. His physical examination reveals a normal gait, pain with squat, reduced rotation compared to the contralateral side, as well as positive impingement and Faber signs. Radiographs reveal a cam lesion illustrated by the red arrow, a pincer lesion by the yellow, and a mildly increased center edge angle. A lateral x-ray shows the same cam lesion, but is better appreciated on the AP view. Preoperative 1.5 Tesla MRA shows a questionable labral tear based upon intrasubstance signal change with intact articular cartilage. Here's an arthroscopic assessment of the acetabular chondrolabral transitional zone using a standard hip arthroscopy setup and a 70-degree arthroscope from the anterolateral portal. The partial labral detachment seen here is typical and is present from the 2 o'clock to the 10 o'clock positions. Here, significant chondral delamination is seen. We estimate an unstable flap 4 cm squared to be present at the 1 to 2 o'clock position, which is consistent with the weight-bearing dome. The flap is based distally and is clearly torn completely away from the transitional zone. There is also delamination at the 10 to 12 o'clock position. Thus, given the patient's age, the extent of the disease, and its location, the decision was made to proceed with pincer takedown with labral preservation, labral repair, limited chondral debridement, and microfracture. Here, intraoperative fluoroscopy is used to confirm our location, and 4.5 mm round burr is used to take down the pincer lesion after preparing the interval between the capsule and the labrum. A total of 4 mm thickness was resected here, moving toward the chondrolabral junction but not violating it. We confirm our resection with fluoroscopy. Using a vertical mattress technique, number 2 fiber wire is passed with a curved suture passer. Here we are at the 1 o'clock position over the chondral flap, and 2 anchors have already been placed at the 11 and 12 o'clock positions. The suture is passed deep to the transitional zone to capture the entirety of the labrum as well as some of the unstable flap. The suture passer is again placed through the labrum, now at the periphery, as the labrum is wide enough to accommodate both passes with the vertical mattress technique. It is also apparent that the chondral flap cannot be secured with this technique as the fiber wire tears through the cartilage. As we drill for our suture anchor, we visualize the joint space to ensure there is no injury to the cartilage. Next, an Arthrex 2.9 by 15.5 mm knotless peak push-lock suture anchor is placed. After repairing the labrum, some of the cartilage has been stabilized at the 10 to 12 o'clock positions, and we are more accurately able to assess the extent of unstable chondral debridement required using an arthroscopic biter. Microfracture is performed using a 0.9 mm drill with a 60-degree curve to facilitate its passage to a depth of 7 mm. We place the holes 3 mm apart. To limit resection of the cartilage, we microfracture through the adjacent cartilage. We assess the adequacy of our procedure by the presence of bleeding from the drill holes, which is seen here, but may sometimes require decreasing the intra-articular pressure and inflow. The repair is again reassessed, the labrum is firmly attached, and the vertical mattress technique does not leave any visible suture that would be interposed between the labrum and the femur. We then release traction to confirm the suction seal effect of the labrum. This is visible from the peripheral compartment as we perform our cam femoroplasty.